Dear Mr. Chairman, ladies and gentlemen, I'm glad to be here. We have this morning, my wife sent me a picture from Munich. We had snow in the garden, so it's wonderful to be here in the Mediterranean. I am the director of a hospital in Upper Bavaria for the last 6 or 7 months, which is located near the location where the last G7 summit was, with Obama visiting Upper Bavaria. Therefore, this is my new starter slide at the moment. For those of you who are not too involved in drug abuse treatment, some data on epidemiology of drug use worldwide. First, on the international level, we have about 200 million people worldwide who take cannabis, about 50 million who take amphetamines. Ecstasy consumption is about 26 million. Do I have to smile again, or we're finished? Okay. About 22 million who take opioids, and about 20 million people who are hooked on cocaine. The European situation is that we have in Europe about 1.3 million opioid-dependent patients, or at least problem opioid users. About half of them are in opioid maintenance treatment. This will be the topic of my other speech this evening. In the US, similar figures, about 1.2 million opioid-dependent patients. A few words on diagnosis of drug dependence. First, as you know, in Europe today, we still use the ICD-10 criteria for substance abuse treatment. In ICD-10, we differentiate harmful use, or the old terminology would be misuse. This is defined as a medical or psychiatric, not a social disorder associated with substance abuse, let's say substance abuse-induced depression. And dependence. Dependence is a broad variety of symptoms. 3 out of 6 define the dependence spectrum: craving, withdrawal, tolerance, dose increase, loss of control, which I think is one of the key features of substance abuse disorders, and social consequences, neglect of negative consequences of substance abuse, and so on. In DSM-5, the ICD-10 has these 6 key features. In DSM-5, as in ICD-10, a number of different classes of abuse are defined, including opioid disorder, cocaine, amphetamine, and alcohol, as in ICD-10. But what is new in DSM-5 is that DSM-5 has given up the categorical distinction between misuse or harmful use and dependence, and adopted a dimensional approach. They have 11 symptoms included in DSM-5 for substance abuse disorders as a broad spectrum. In 2 or 3 symptoms would mean a light, 4 to 5 symptoms fulfilled, a moderate, 6 or more, a severe disorder. This is a totally new, not unproblematic spectrum of diagnosis in DSM-5. And as you can see here, for alcoholism, if you have 3 or 4 symptoms, 2 or 3 symptoms fulfilled, this is a mild alcohol use disorder. Would be the same for opioid disorder, and severe would be 6 or more. We have a brief introduction about what is happening in the brain when you are addicted. We know quite well that there are certain brain areas which have a high importance for the reliability of an individual to get addicted. There is a reward system in the brain, the reward prediction and pleasure system, basically in the mesolimbic areas. There are dopaminergic projections into the prefrontal and frontal cortex, where the cognitive control about what I consumed is represented. Other brain areas involved are those responsible for learning and memory and for motivation, marked here in this slide. So these are the brain areas which play a substantial role for addiction. On the neurochemical level, all substances who have an addictive potential cause some form of dopamine release in the nucleus accumbens. Some do it fast, some do it slowly, some do it directly like cocaine and amphetamines, some do it indirectly like alcohol, but in the end, all drugs of abuse target this key area, ventral tegmentum area and nucleus accumbens. Drugs of abuse induce a dopamine release in this area. In the real world, it's even more complex. It's not just as a drug induces dopamine by itself, by taking the drug, but the new research has indicated that already the anticipation of a reward, I expect something to take, I expect something to consume, I go to the bar and I expect to have a drink or to take a drug, this already leads to a dopamine release in this area. So it's a reward anticipation system as well. And now a few words about how often is substance abuse in other psychiatric disorders. There are a number of broad epidemiological studies who have targeted this. An old but still very important study in the 1990s but in the US conducted indicated that in affective and depressive disorders there's about a two-fold increased risk for substance abuse, basically alcoholism, but not only. As depressive patients have a double as high risk than the normal population. It's extremely high in the population. Dr. Grunze is watching closely in bipolar patients. There's an absolute excessive rate of substance abuse treatment in bipolar 1 and bipolar 2 patients, about 6 or 7 times higher than in the normal population. That means about 40% of patients are involved. So there's a great comorbidity in this study for bipolar disorder and substance abuse treatments. There are other epidemiological studies, as the one by Uli Wittchen and others, who has shown that there's a broad overlap of different psychiatric disorders. There's a broad overlap for anxiety disorders and substance abuse disorders, and of affective disorders and of others. So one way or the other, you can put it any way, you find a very high rate of comorbidity, especially with substance abuse disorders, both for anxiety and for depression. About 2.5 increased risk for anxiety disorders in patients with substance abuse, 2.7 increased risk for depression, and vice versa. And there are some more recent studies from the US, the studies by Grant et al. They conducted a big national epidemiological survey on alcoholism and related disorders. 36,000 interviews in adults conducted, an enormous number of individuals, not patients, individuals have been screened. And what this study showed, that there's a high rate of alcohol use in the general population. That's not a surprise. And they quite exactly figured out how strong is the association between different psychiatric disorders and alcoholism. And as you can see here, there's not an excessive high risk for most of psychiatric disorders in substance abuse patients, but there is a risk. Bipolar patients have a stronger association than other mood disorders, but in the general there's an increased risk for depressive disorders. There's a slightly increased risk for anxiety disorders, and of course also for different kinds of personality disorders. The odds ratios are all about 1, so there is a significant increased risk for psychiatric disorders in substance abuse patients as well. This is the Psychiatric Congress. There are a lot of psychiatric colleagues here in this room as well, and therefore just one word about the frequency on substance abuse disorders in physicians, a topic which I'm interested in recent years. And there's a quite interesting study from the US about the risk of substance abuse in different medical professions, and as they turned out, I hope you can read it, the highest risk of alcoholism is in dermatologists for some reason, followed by orthopedics. Psychiatric is in the midfield, and in all statistics I know pediatrics are the most healthiest doctors. They have the lowest risk of alcoholism, and as these studies also show, it is quite frequently associated with professional stress and with depression. As you can see it in doctors as well. How are alcoholic patients treated? This is a novel German studies basically performed in general practitioners, and they were asked, what do you give to patients who have an alcohol problem? If there's somebody with an alcohol problem in your private practice, what kind of medication do you give him? And the specialist says we give, 68% of specialists say we give a medication. In the GPs it was about a third, 31%. That's not a big surprise. There are a few specific medications for the treatment of alcoholism. This will be the topic for tomorrow. This is acamprosate or disulfiram or naltrexone, rarely given to alcoholic patients by GPs or by specialists, as for baclofen. But what they do, they give for the alcoholic patients, not depressed patients, alcoholic patients. The specialists, the psychiatrist, 45% recommend antidepressants for treatment of alcoholism in alcoholic patients, and the GP, maybe in a desperate situation, also 22% decide we give an antidepressant to an alcoholic patient. This is a surprising figure, of course, because this is not evidence-based at all, other that antidepressants do any good for alcohol treatment, but this is what the reality is in private practice. What is the medical basis? What do studies tell us? I will basically focus on studies on antidepressants and comorbid alcohol dependence and depression. There are only a handful of studies in other conditions on anxiety. There's hardly any relevant study on schizophrenia and substance abuse treatment. But in depression and alcoholism, there are at least a handful of studies which deserve some attention. In the recent years, there have been conducted 4 systematic reviews and meta-analysis on this topic by, I don't know the pronunciation, Nunes et al., Torrance, Eviano, and Foles. What do these meta-analyses tell us? Now, first, the oldest meta-analysis by Nunes in 2004 published. This group included 14 randomized clinical studies in their review, and what they have shown is there were moderate effects of antidepressants, various substances use compared to placebo in patients with depression and alcohol or drug use disorders. If you look at just the studies with alcoholic patients, these were 8 studies. Again, there's a moderate effect of antidepressants on depression in this comorbid patients. The other meta-analysis has been done by Torrance and colleague. In brief, there were no effect on SSRIs. A few studies with SSRIs, but most have shown negative effects. No effects of SSRIs on alcohol intake and on depression. The other antidepressants had moderate effects. The newer meta-analyses are more relevant. By Ioveno et al. In 2011, 12 studies were included in this meta-analysis, and again the study showed small effects, small but significant effects on outcome in comorbid patients, more on depression than on the alcohol use. In fact, by and large, there's a broad consensus that the alcohol intake is not affected by the treatment with antidepressants. It's the patients with alcoholism do not drink less when they are on antidepressants, and there are a number of side effects and interactions and so on. Also, it's not a good idea to give antidepressants to patients just for reduction of alcohol intake, but it has effects on the depressive symptomatology. And the last meta-analysis published recently in 2015 was by Falls. The database by that time had increased to 22 clinical studies that were measured. 13 studies were on antidepressants versus placebo in patients with alcohol dependence and depression, and 9 studies were combined with other interventions, basically psychotherapy. Now, the results, there were again an overall improvement of depressive symptoms with antidepressive treatment. The effect was stronger in primary depression than in alcohol-induced depression. This is a diagnostic dilemma which we have clinically, but also in a lot of studies. Alcohol and drug abuse, but especially alcohol abuse, can of course cause depression per se. It's difficult to diagnose, and most guidelines recommend wait a few weeks before you make the diagnosis of a depression in patients with substance abuse, because in many patients the depression will go away when the drug is not longer present. Good recommendation, but there are also patients who have a primary independent depression, and in those individuals who have a clear depression, the treatment with antidepressants is much more effective than those who have a however defined alcohol-induced depression. That's quite clear in the studies. And now something new that what you cannot know because it is not published. It's always good to have some new data. There's a Cochrane analysis underway. It's under review, and since I'm one of the reviewers, I know the data. This will be released in a few weeks' time, hopefully, by Agabio and others. This is a Cochrane analysis on the question, do antidepressants work in substance abuse patients? And in this under review Cochrane analysis, 32 studies involving about 2,200 patients were included. The drugs used in these studies measured was a wide mixture of drugs, mostly sertraline, which only have one S, not two double S. That's a misspelling. I apologize for that. It's sertraline. But also amitriptyline, citalopram, escitalopram, and other drugs. Wide range of antidepressants used in these different studies in this meta-analysis. What are the recommendations derived from the study of Agabio? First of all, if you look at those studies comparing antidepressants with placebo, dropout rate was similar, either on placebo than on the antidepressants, no higher dropout rate when you are on medication. Antidepressives are better than placebo in depression treatment, but the level of evidence for this is not very good. Very low quality evidence, as they say in the Cochrane analysis. So there is some evidence, but not a very strong evidence. Again, if you look at treatment outcome with respect to alcohol intake, the number of abstinent days as a primary outcome is not different between antidepressant treatment and placebo. Again, the finding that antidepressants do not reduce alcohol intake in alcoholics with depression. And if you look at the alcohol intake in general, either the grams per day or gram of alcohol per day, or the drinks per day, this is an American way to count the treatment outcome, or other alcohol parameters. Either way you look at it, there's a slight evidence for a somehow lower alcohol intake in comorbid patients when they are on antidepressants, but far beyond a level where you would say, okay, this is relevant for treatment. So alcoholism does not improve by treatment of antidepressants. What are the conclusions? No convincing evidence for antidepressants to be effective in depression plus alcohol dependence when it comes to alcoholism, and moderate evidence that it works for the treatment of depression. So there is a limited, but I would say at least some database on the effectiveness of antidepressants in comorbid patients, and the bottom line is quite clear. You can give it for treatment of depression, but it does not alter the alcohol intake. For those who have a pronounced interest in that area, there are a number of textbooks on this issue. There's one fairly recent English textbook, Co-occurring Addictive and Psychiatric Disorders. One of my Swiss colleagues, Franz Moggi, a psychologist from Bern, and colleagues from the Netherlands had edited one. This Heinz Grunze and I had one or two chapters in this book. This gives a fairly good review on the database which exists so far, and there's also a German textbook saying basically the same. And I come to the end. This is again Barack Obama at the local Bavarian G7 summit last year. Thanks for your attention, and I'm happy to answer questions if they are available. Thank you.